we'll get it. Mic's on? Okay, there we go. All right, welcome. We're glad to have Abby Frye here today. She's been doing this pharmacology grand rounds lectures for us for a number of years, and they're some of my favorite. I'm going to introduce Abby to you. She's originally from Iowa, did her undergraduate there in chemistry, and then she did her pharmacy PharmD at University of Washington. She did her residency here at Providence, and she's currently at St. Vincent's in the residency program there. And she is the face behind the RX Hot Topics emails that we get that are so useful and helpful. And she's here to give us another collection of pharmacy topics. So welcome, Abby.
All right, thank you. Can everybody hear me okay now, since I did a little mic switch? We're good? All right. Thanks for that introduction, and also thanks for the invite to come back and do this grand rounds. I always look forward to it. As Jesse mentioned, I am one of the editors of our department's RX Hot Topics. It's the Providence Medical Group Clinical Pharmacy Department's clinical newsletter of sorts, where we try to highlight some of those topics that we think are most pertinent to primary care providers, whether it be a clinical trial, a guideline update, such as the hypertension guideline update we sent out earlier this year, or more recently, the cholesterol guideline update, FDA updates, including new drug approvals, or new warnings or alerts, or more recently, recalls have been the bane of my existence, and then also some clinical and prescribing pearls. The objectives of our printed or distributed RX Hot Topics, as well as today's grand rounds, are to evaluate recent studies that provide pertinent information about medications, to identify emerging safety concerns with commonly prescribed medications, and to discuss new evidence that clarifies the role of established therapies. Today, specifically, the topics I'm going to review include some emerging evidence about the high-dose flu vaccine. I'm going to look at the approval of a new drug to treat influenza, 3 recent aspirin trials that have been published this year, a closer look at a study linking ACE inhibitors and an increased risk of lung cancer, and then lastly, the 2018 CHEST guideline. I hope you enjoy some of those topics, as well as my pictures that are going to help me transition from one topic to the next. Today, they are from a trip this summer around Mount Blanc, so hopefully the topics and the pictures are enjoyable. So our first topic is one that created a lot of buzz, I think in part due to this headline in the Oregonian that said, "Seniors should get high-dose flu shots, Oregon study says." So this generated a lot of questions from patients and providers, and so I recently put out kind of a summary of this study. Before we get into the study details, just by way of some background, the high-dose flu vaccine was created because, as we all know, seniors are at an increased risk of adverse outcomes related to the flu and are less likely to generate a sufficient or as great of an immune response to the standard dose vaccine. So the high-dose flu vaccine tries to overcome that by containing 4 times the antigen as the standard dose vaccine. It is a trivalent product, meaning it contains 2 A strains and 1 B strain, whereas the current standard dose vaccines are all quadrivalent, so they have an extra B strain. The high-dose vaccine is approved for use in adults 65 and age of older, and I think it is important to highlight there's a modest cost difference. Now, what the actual price to the patient is of course, dependent on formulary coverage, but if you were to pay cash for it at a pharmacy, there would be a cost difference. One kind of advertisement online I found was $70 for a high-dose vaccine at a retail pharmacy versus $50 for a standard dose vaccine. So prior to this most recent study, we do have some evidence regarding the effectiveness of the high-dose vaccine versus a standard dose vaccine. The highest quality evidence came from a randomized controlled trial published in 2014. In this case, the high-dose vaccine, again, a trivalent product, was compared to a trivalent standard dose vaccine. As I mentioned, currently the standard dose vaccine is quadrivalent, but historically it was trivalent, and so that was what was compared in this trial. In this trial, there were nearly 32,000 patients, 65 years of age or older, in the United States and Canada, and the primary endpoint was laboratory-confirmed influenza. And there was a reduced risk in the high-dose vaccine group, incidence of 1.4% versus 1.9% for a number needed to treat of 200 over 2 years. In a more recently published meta-analysis, this was published earlier this year, the investigators included 7 studies, again, all comparing high-dose vaccine versus a trivalent standard dose product. And in conclusion, they found that the high-dose vaccine was more effective at preventing influenza-like illness, hospital admissions, pneumonia, and cardiorespiratory events. However, I think this data is somewhat limited given that the current standard dose product is quadrivalent, so we aren't really comparing the current high-dose product with our current standard dose product. So that brings us to the current CDC recommendation. The CDC recommends that persons 65 years of age or older should receive any age-appropriate influenza vaccine. That includes standard dose, high dose, trivalent or quadrivalent, or the adjuvanted or the unadjuvanted. They mention kind of in the fine print that there is evidence suggesting that the high-dose vaccine may be more effective. However, that should not delay immunization. If you have an appropriate immunization, you shouldn't delay that in order to find a specific one. So that brings us to the most recent study, the 2018 Oregon study. This was a matched cohort study. The population was seniors aged 65 years or older, residing in the greater Portland area during the 2016-17 flu season. Patients were included if they had reported influenza immunization by December 11th, 2016, and that was based on when flu was present in the community. The primary outcome in this trial was laboratory-confirmed influenza-related hospitalization. In total, there were 23,000, nearly 24,000 matched pairs. They were kind of well matched on exact age, gender, residence type, their race or ethnicity, provider bias, and residence area determined by zip code. So they're really highly matched on those criteria in order to try to eliminate various biases. As I mentioned, the primary outcome was influenza-related hospitalization, and there was statistically significantly fewer in the high-dose group. This 30% risk reduction is what was quoted in the publications and in the Oregonian, which looks significant, but I think it's important to look at the absolute risk reduction, which is not nearly as impressive. So there's a 0.15% absolute risk reduction, which calculates to a number needed to treat of 667. So when we look at the absolute risk reduction, it's very small comparatively to that relative risk reduction that was reported in the publications. So in summary, the high-dose influenza vaccine does appear to be more effective than the standard dose vaccine, historically compared to the trivalent standard dose, and then in this trial compared to a quadrivalent standard dose. One thing I failed to mention, the 2016-17 flu season, the available standard dose product was quadrivalent, so in this case it was compared to what we currently have. So the high-dose vaccine does appear to be more effective in elderly adults. However, that absolute risk reduction is small, and I think very small. As a result, vaccination should not be delayed to find a particular product. If a patient who is 65 years of age or older wants to go get the high-dose vaccine, I think that'd be a reasonable recommendation. But if you have the standard dose vaccine, that would also be an appropriate immunization. It is also very effective. Okay. So our next topic, somewhat related in this case, the new treatment for the influenza. So that new treatment is called baloxavir. The brand name is Xofluza. It provides a new mechanism of action compared to our neuraminidase inhibitors, which block viral release. In this case, baloxavir blocks viral replication. It has activity against influenza A and B, and it's indicated for the treatment of acute, uncomplicated influenza in patients 12 years of age or older who have had their flu symptoms for less than 48 hours. It is a one-time dose, which is always nice for patients, so it's 40 milligrams times 1 for patients less than 80 kilograms, or 80 milligrams times 1 for patients 80 kilograms or heavier. And the cost, when I looked it up, it is available, and the cash price would be around $150 for that one dose. Obviously, price to patient depends on their coverage. So the evidence for approval for baloxavir comes from this phase 3 trial called Capstone 1. It was a randomized, double-blind, placebo and oseltamivir controlled trial. There were over 1,400 outpatients aged 12 to 64 with influenza-like illness, and it was conducted during the 2016-17 flu season. It's really important to highlight some of the exclusion criteria. Patients with chronic underlying conditions, this included pregnant women, those weighing less than 40 kilograms, or those with illnesses that resulted in hospitalization were all excluded. So these were relatively healthy, community-dwelling adults and some pediatrics. The intervention was baloxavir or oseltamivir or matching placebos. And in this case, the primary endpoint was time to alleviation of influenza symptoms and the intention to treat infected populations. So things like they evaluated when things like cough, sore throat, headache had resolved. So in the trial, over half of patients initiated the medication within 24 hours of symptom onset. And I think that's important to highlight because I think logistically in clinical practice, that's often pretty hard to achieve. The median time to alleviation of symptoms was about 53 hours in the baloxavir group and similar in the oseltamivir group, so obviously no clinically or statistically significant difference between the treatment arms. In the placebo arm, the median time to alleviation of symptoms was 80 hours. So that's a difference of just over 26 hours between the baloxavir arm and the placebo arm. In terms of adverse events, all treatments were pretty well tolerated. So adverse events similar or even less than placebo. The only one that was specifically more common in the oseltamivir treatment arm was nausea. Nausea was less common with baloxavir, but the incidence of nausea even with oseltamivir is quite low, so just 3% and all pretty mild. So both treatments seem to be pretty well tolerated. So that brings us to the CDC's recommendation. So baloxavir joins oral oseltamivir, inhaled zanimivir, and IV peramivir for the treatment of influenza. As you can see, it is not indicated or recommended for the prophylaxis, so only for the treatment in those 12 years of age or older. So in summary, oseltamivir or Tamiflu remains the treatment of choice for those high-risk and severely ill patients. There is limited or no evidence for the use of this new product, baloxavir, in the high-risk patients who are going to be most likely to benefit from antivirals. So it hasn't been studied in those very young patients, less than 2, elderly patients over 65, those with chronic conditions, those who are severely ill or hospitalized, or those who are pregnant. For those kind of reasonably healthy patients, if either they or you really want to treat them with a antiviral, it is a potential alternative to oseltamivir for acute uncomplicated influenza. But some big caveats here is that if it can be started within 48 hours of illness onset, there's been no evidence of its benefit or effectiveness if it's beyond that 48 hours. And as I mentioned, about half of the patients actually started within 24 hours. It does have the advantage of being a one-time dose, but it is modestly more expensive than oseltamivir. And we just don't have kind of as long of a body of evidence regarding any other risks or risk of resistance. All right. So moving on to a completely unrelated topic, looking at aspirin for primary prevention. So the benefit of aspirin in patients who do have cardiovascular disease, those with ACS or a history of an MI or history of stroke or TIA, has been really well established. Lots of studies, a wealth of evidence regarding the benefit in that population. However, the use of aspirin for patients for primary prevention has remained controversial despite lots and a long duration of randomized trials. So this year there's been 3 new trials looking at the use of aspirin for primary prevention. First of all, before we get into the trials, I want to look at the current recommendations for the use of aspirin in primary prevention. So this is the USPSTF recommendation. This was updated in 2016, I believe, and they recommend initiating low-dose aspirin for primary prevention of both cardiovascular disease and colorectal cancer for patients who are 50 to 59 years of age with a 10-year CVD risk of 10% or greater, as long as that patient doesn't have an increased risk of bleeding and is willing to take the aspirin for 10 years. And they gave that a grade B recommendation. Kind of beyond that population, the recommendations become less strong or even non-existent from the USPSTF. So they recommend considering it in patients 60 to 69 years of age who have that 10-year risk of over 10%, but indicate that the evidence is not as strong and it really needs to be based on a case-by-case basis, patients' preferences, patients' bleed risk, and their life expectancy. For patients less than 50 years of age and 70 years of age or older, there's insufficient evidence to provide a recommendation. We also have a recommendation regarding the use of aspirin for primary prevention from the ADA. In their 2018 Standards of Medical Care, they have a grade C recommendation indicating that aspirin at a low dose may be considered for primary prevention for patients with type 1 or type 2 diabetes who are at an increased cardiovascular risk. And they go on to define that as men or women with diabetes, 50 years of age or older, who have at least one additional risk factor. Family history of premature ASCVD, hypertension, dyslipidemia, smoking, or albuminuria. So those are our current recommendations for use of aspirin for primary prevention, and now I'll get into the 3 most recent trials. All 3 of these trials looked at different populations who are considered to be at an increased risk of cardiovascular disease. The first trial, the ASCEND trial, looked at the diabetes population. So this was a randomized, double-blind, placebo-controlled trial. It included over 15,000 adults who had diabetes, were 40 years of age or older, and did not have any known cardiovascular disease. They were randomized to 100 milligrams of enteric-coated aspirin or placebo, and the primary efficacy endpoint was kind of one of our usual composite outcomes of non-fatal stroke or MI, TIA, or death from vascular cause. The primary safety endpoint was major bleeding, defined as composite of confirmed intracranial hemorrhage, sight-threatening bleeding in the eye, GI bleeding, or any other serious bleeding leading to hospitalization, transfusion, or fatality. Patients were followed for a median of over 7 years. And as far as results, the population on average was 63 years of age, 62% were male, a vast majority were white. 94% of them had type 2 diabetes, and in terms of those risk factors that are going to increase their risk of cardiovascular disease, 62% had hypertension, 8% were current smokers, 45% former smokers, and 75% were on a statin. So it seems kind of like our typical type 2 diabetes population. The limitation is that it really only provides us with evidence about white patients. In terms of outcomes, there was a statistically significant benefit in terms of the primary efficacy outcome, which again was that composite of cardiovascular events and TIA, with a number needed to treat of 91. However, that was really kind of outweighed or balanced by the increased risk of harm, so an increased risk of that major bleeding as the primary safety outcome, which had a number needed to harm of 112. So kind of the, at least in my assessment, the harms associated with low-dose aspirin might outweigh the benefits in this population. The second aspirin trial that was just published this year is the ARRIVE trial. This looked at a more general population. They excluded those with diabetes, but included kind of this general population of patients who have a average or moderate cardiovascular risk. They included over 12,000 patients. Inclusion criteria was 55 years of age or older for men, and 60 was the cutoff for women who had a 10 to 20% estimated 10-year coronary heart disease risk. They quantified that further as men with 2 to 4 risk factors and women with 3 or more risk factors of the following. So high cholesterol, low HDL, current smoking, high blood pressure or on medication for high blood pressure, and then a positive family history of ASCVD. Once again, the intervention was 100 milligrams of enteric-coated aspirin or placebo, and they again looked at that composite outcome of time to first occurrence of cardiovascular death, MI, unstable angina, stroke, or TIA. In this case, the median follow-up was 5 years. So the patient population, on average 64 years of age, mostly male. Again, a vast majority were white. In terms of those risk factors, 65% in this case had hypertension, 29% were smokers, 43% were on a statin, and they estimated that the average ACC-AHA risk was 17% at baseline. In terms of outcomes, there was no statistical difference in terms of the primary composite outcome of MI, stroke, cardiovascular death. I think it is important to note that their actual cardiovascular event rate was much lower than predicted. So as I mentioned, the mean ACC-AHA 10-year risk was 17%. They only saw about 4% over 5 years, so less than 10% over a 10-year period. So it seems that not sure if it was over-predicting it or just we're better managing our cardiovascular risk of our patients, but it was a much lower rate than expected. In this case, it's not pictured here in the slide, but the investigators looked at the per protocol population as well. Those were patients who were at least 60% adherent to aspirin during the study period. And in that population, again, the primary efficacy outcome was not significantly different, but there was a benefit in terms of MI. So there was less MI in the per protocol population who were more adherent to aspirin during this period. So back to the kind of key secondary outcomes, there was not a significant difference in serious adverse events overall, but there was a significant increase in GI bleeds in those patients who were treated with aspirin, with a number needed to harm of nearly 200. And finally, the third trial that was released this year about aspirin and for primary prevention was the ESPRIT trial. This was, again, a large trial. The patient population in this case were healthy adults 70 years of age or older. The intention here was to look at those patients who we know are older patients are at a greater cardiovascular disease risk, and so specifically looking at that population. These patients were 70 years of age or older. They did include some younger patients if they were Black or Hispanic in the United States, but none of the patients had cardiovascular disease or dementia or physical disability, so kind of our healthy community-dwelling adults. The intervention was the same, 100 milligrams of enteric-coated aspirin or placebo. But the primary endpoint was a little different in this case. It was disability-free survival, so a composite of death, dementia, or persistent physical disability. They did have some other secondary endpoints. Cardiovascular disease was looked at, all-cause mortality, and then our safety outcome of a composite of hemorrhagic stroke, symptomatic intracranial bleeding, or clinically significant extracranial bleeding. The median follow-up was nearly 5 years in this case as well. In terms of that population that was included, the median age was 74 years. A little bit better mix of men and women, 44% male in this case. 85% of the population was white. And then as far as those risk factors, 74% of the population had hypertension, 4% were current smokers, 11% had diabetes, and 65% had dyslipidemia. The primary outcome, again, was that disability-free survival, and there was no significant benefit associated with aspirin in terms of that primary outcome. There was also no significant benefit in terms of cardiovascular disease in this population. However, there was a significant increase in the risk of major bleeding, with a number needed to harm of 97. And they also noticed a significant increase in the risk of all-cause mortality. This increased risk of major bleeding was kind of fueled by an increase in intracranial bleeding and upper GI bleeding. And all-cause mortality, the main reason for death was an increased risk of cancer death, actually, in the aspirin population. So what did we get from these three recent trials? These three trials evaluated the use of low-dose aspirin in 3 populations of patients who we know have an elevated risk of cardiovascular disease. They looked at patients with diabetes in one trial, kind of our healthy elderly patients in another trial, and then those patients with 2 to 3 cardiovascular disease risk factors. In all 3 of these trials, low-dose aspirin was associated with a higher risk of major bleeding. I don't think that's a surprise to any of us, but then was no to minimal benefit in terms of those cardiovascular disease-related outcomes. So I think in total, what I get out of these trials is that the risk of bleeding associated with low-dose aspirin likely outweighs the potential for benefit for most of our patients who do not have a history of cardiovascular disease. Okay. All right, so our next topic is a recent study that has also generated some headlines regarding the association between ACE inhibitors and lung cancer. So as far as some background, this relationship or association is biologically plausible. So ACE inhibitors cause an accumulation of bradykinin and substance P, and both of those have been reported to either stimulate growth of lung cancer or have been associated with tumor proliferation and angiogenesis. However, the results from previous observational trials have been mixed and limited, and so the investigators sought to take a closer look. The study design in this case was a retrospective population-based cohort study, which used the UK CPRD, or Clinical Practice Research Data Link. That data link includes data from approximately 700 general practices in the UK, which comprises over 15 million patients. In this case, the study population was nearly 1 million patients who were newly treated with an antihypertensive between January of 1995 and December of 2015. And that 1995 date was picked because that was the first year that both ACEs and ARBs were available in the UK. Patients with a history of cancer were excluded, and the mean follow-up was over 6 years. The primary endpoint that they were looking at was the lung cancer incidence associated with the use of ACE inhibitors compared to the use of ARBs, and they adjusted for age, sex, year of cohort entry, body mass index, smoking status, alcohol-related disorders, and history of lung disease, so some of those other factors that may increase the risk of lung cancer. In terms of results, during the follow-up period, over 300,000 patients were treated with ACE inhibitors, 29,000 patients were treated with ARBs, and then 100,000 patients were treated with both ACEs and ARBs. The most commonly used ACE inhibitors were ramipril and ensipril, which are, I think, more commonly used here, as well as a less commonly used ACE, the perindopril. Nearly 8,000 patients were newly diagnosed with lung cancer during the follow-up period, which was associated with a crude incidence rate of 1.3 per 1,000 patient years. So when they looked at ACEs versus ARBs, they did see an increased risk associated with the use of ACE inhibitors in that general population. In subgroup analyses, they found that this risk was higher with longer duration of use of the ACE inhibitor. So the risk was not significant for use less than 5 years, but did become significant with use more than 5 years and increased with use over 10 years. In a separate subgroup analysis, they also found that the time since first use of the ACE inhibitor with over 10 years was associated with increased risk of the lung cancer. So what do we make of this? I think based on this evidence, we would have to conclude that this study shows that when used for more than 5 years, ACE inhibitors may be associated with a modest increase in the risk of lung cancer, but our retrospective studies cannot establish causation. So additional studies to corroborate these findings are most certainly needed to establish that causation and help us really understand how to use this evidence. I don't think this evidence would suggest that you stop prescribing ACE inhibitors. We have lots of evidence regarding the benefits of ACE inhibitors, and this again does not establish causation, but if a patient or a provider is particularly concerned about this risk, then since we have ARBs, which also have good evidence for most of the same indications, I think that could be a consideration. So as a caveat, lately ARBs have been on the recall list for reasons related to cancer as well, but not all ARBs are recalled, not all ARBs are affected. So I think there are alternatives if a patient or provider is particularly concerned about this risk. Okay. And one more topic before we have some time for questions and comments on all of these topics. So our final topic is the 2018 CHEST guideline on antithrombotic therapy for atrial fibrillation. As I mentioned, kind of guideline updates are one of the things we like to highlight in our RX Hot Topics newsletter. Earlier this year, we highlighted the hypertension guideline update. Just this week, we sent out a summary of the cholesterol guideline update, and one that we're working on is the antithrombotic therapy for atrial fibrillation update. So we'll talk a little bit about the key points of that update here. So the first key point was that the guidelines call for the use of the CHADS-2 VASC. Previous guidelines were released in 2012, and at that time the CHADS-2 was being used. But they recommend the use of the CHADS-2 VASC to better identify those low-risk patients who do not require anticoagulation. So for males with a risk score of 0 or females with a risk score of 1 on the CHADS-2 VASC, then no anticoagulation is recommended. However, for those patients with at least one non-sex risk factor, they should be offered antithrombotic therapy. And in a big shift from previous guidelines, the 2018 CHEST guidelines recommend direct oral anticoagulants over warfarin when prescribing anticoagulant therapy. They do mention that when warfarin is used, a time in therapeutic range of over 70% should be targeted and recommended, but this is a big shift that I want to take a little closer look at, is this recommendation for direct oral anticoagulants over warfarin. So the reason for that shift primarily comes from pooled evidence that suggests that direct oral anticoagulants are more effective than warfarin. So this is a summary of that pooled evidence, which showed a statistically significant reduction in stroke and systemic embolism associated with the DOACs, or direct oral anticoagulants, over warfarin. However, I think it's important to look that ischemic stroke appears similar, but there was that reduction in stroke comes from the reduction in hemorrhagic stroke specifically. There's also a reduction in intracranial hemorrhage associated with the direct oral anticoagulants. However, there was an increased risk of GI bleeding from this pooled data, this pooled data comes from those large phase 3 trials for each of the direct oral anticoagulants. However, I think this is one of those areas where I think it deserves a little closer look because a minority of patients in the DOAC trials were from North America and Western Europe. And again, that pooled data is from those large phase 3 trials. And we know that well-managed warfarin, meaning time in therapeutic range over 70% ideally, is associated with lower rates of stroke, major bleeding, and death than was reported in the DOAC trials. That is evidence from this data here. So that this is a table showing the event rates described as percent per year for some of those major endpoints: stroke, major bleeding, death, intracranial hemorrhage, from the DOAC studies, as well as compared to other analyses. So as I mentioned, a minority of patients in the DOAC trials were from North America and Europe. So they've compared those to some different analyses that are from Western Europe. So the EAA is the European Action on Anticoagulation. This is a network of clinics which reports outcomes from Europe with nearly just it's a small study, or a small population of about 6,000 patients with atrial fibrillation. And then the Sweden study had about 40,000 patients, obviously from Sweden, who were on vitamin K antagonists. So as you can see in those EAA study and the Sweden study, the percent per year event rates for patients on warfarin are much lower than those shown in the DOAC trials. So if we look at specifically the highlighted Sweden study, in the overall population, the percent per year event rate for major bleeding, for example, was 2.23. In the DOAC trials, the percent per year event rate for warfarin was 3 to 3.4. When we look at a subpopulation of patients in the Sweden study who had a time in therapeutic range over 70%, so that's really what we consider well-managed warfarin therapy, those event rates came down even lower. So what does this all mean? Does it mean I'm favoring warfarin over DOACs? Not necessarily, but I think that decision has to be quite nuanced. Obviously, the DOACs offer several advantages compared to warfarin. More predictable pharmacokinetics, a quicker on-off, you don't need to monitor INR. However, I think some of this evidence shows us that the clinical advantages observed in the phase 3 trials, which really is responsible for that shift in the guideline recommendation from warfarin to DOACs as the preferred therapy, those clinical advantages may be less significant if the DOACs are compared to really well-managed warfarin therapy. So despite the general preference for DOACs, warfarin still may be the preferred anticoagulant option. I think that can sometimes be lost when kind of the big recommendation is we prefer DOACs over warfarin. So those patients who warfarin might be preferred is going to be based on patient-specific characteristics, things like their weight, their renal function, their preferences and your preferences, the cost. We all know that DOACs are a lot more expensive than warfarin for some patients in terms of drug cost. The anticipated adherence to medications or their compliance with INR monitoring. And finally, the availability of measures that increase the success of warfarin management. So the availability of anticoag clinics, for example, really increases the ability to be successful with warfarin management and achieve a really good time in therapeutic range. And that probably should be weighed when considering DOAC versus warfarin. So back to the guidelines and some of the key points. Another key point from the guideline was that bleeding risk should be assessed at each patient contact. And then based on that bleeding risk assessment, modifiable risk factors such as uncontrolled hypertension, a labile INR, and then drug interactions such as antiplatelet agents, NSAIDs, or excessive alcohol use should be addressed. Anybody that has a HAS-BLED score of 3 or greater warrant more frequent review and follow-up. And this is regardless of anticoagulant used. Number 5, as far as key points, for patients with a history of unprovoked bleeding, bleeding on warfarin, or a high risk of bleeding, the guideline recommends use of apixaban, edoxaban, or dabigatran 110 milligrams, as they have all demonstrated significantly less major bleeding compared to warfarin. And I want to highlight that recommendation because this might be a somewhat confusing one, because when dabigatran was approved for the use of atrial fibrillation, the 110 milligram dose was actually not approved. However, it is approved now. It's FDA approved for the use of VTE prophylaxis after hip surgery, but it actually is more evidence-based when they did the Relay trial, which was the large phase 3 trial of dabigatran versus warfarin for AFib. They did look at dabigatran 150 milligrams and dabigatran 110 milligrams. And that 110 milligram dose is the one that was associated with a lower risk of major bleeding. So this is the first time that the guidelines actually recommend it, but it's a little nuanced since it's not actually approved for that use here in the United States. And then finally, the last key point from these guidelines is that for patients with atrial fibrillation who undergo coronary stenting, the use of multiple antithrombotics should be based on the risk of bleeding and clinical presentation. And this is one of the tables, which I think is probably the most useful from the new guidelines. So this provides guidance on those patients who do need an anticoagulant plus an antiplatelet, or maybe 2 antiplatelets like clopidogrel and aspirin after stenting. So it breaks it down based on clinical presentation, whether it's for ACS undergoing PCI or stenting, or elective PCI with stenting. And then based on their bleeding risk, based on the HAS-BLED score, it provides guidance as far as if and how long dual antiplatelet therapy, or DAPT, or single antiplatelet therapy should be used after that event, and then reminds you that it should be a defined period of time as opposed to indefinitely, because we have really good evidence that combined use of antiplatelet therapy plus the oral anticoagulant significantly increase that risk of bleeding and doesn't provide significant benefit outside of this indication. And with that, you can look at the picture of me catching my breath on the TMB while I answer questions.
What about patients with mechanical aortic valve and not aortic, let's say mitral, and atrial fibrillation?
So the question was about what about mechanical valves and significant valvular disease, I would say, and atrial fibrillation. For those cases, the DOACs, the direct oral anticoagulants, would definitely not be recommended. They are contraindicated for that, and that would be a case where warfarin would be preferred based on those patient characteristics. Would that answer your question? In the back? Yep.
Can you comment on the fact that the 3 studies you presented on low-dose aspirin use a dose of 100 milligrams, whereas the majority
We
of
don't use that.
patients take a dose that is 25% lower than that?
Yeah. So the question was, can I comment on the studies about aspirin that can, all of them had the same intervention of 100 milligrams of aspirin, whereas in this country, we typically use a dose of 81 milligrams. Obviously, I'm not sure how using a lower dose of 81 would affect those results. Would it be a little safer? I don't think we have good evidence comparing 81 to 100. I think we do have evidence that even a low dose of 81 milligrams is associated with increased risk of bleeding. And so I still think that would probably outweigh the fact that the benefit was really mild or non-existent. All of those studies were either conducted in the UK or Europe or Australia, partially in the US, but I think that's probably what drove the use of 100 milligrams versus 81. Yeah.
Some people have questioned the validity of comparing a GI bleed to a vascular event in terms of life-altering and life-ending consequences.
Sure.
Could you comment on that?
Yeah. So the question was, some people have disputed that a GI bleed is maybe not as severe, significant, or life-altering as a cardiovascular disease event. I think that may be true. I think we'd all agree with that. But in some of those trials, the increase was also in intracranial bleeding or fatal bleeds. And so, yes, I think maybe the GI bleed could be kind of weighed. But again, the lack of benefit or the really marginal benefit, I think gets outweighed by some of that bleeding risk. But again, that is where it comes to a patient-specific consideration. If the patient is at really low risk of bleeding and would rather do everything they can to reduce their risk of potential cardiovascular disease, then aspirin might be right for that patient versus other patients. Oh, yes.
So where are they at in terms of reversal agents for the novel anticoagulants or the DOACs?
Yeah.
That was part of the consideration. People were like, well, at least they're playing okay.
Yep. So, great question. So the question was, where are they at with reversal agents for the DOACs? All of them now have a reversal agent. There's a specific one for dabigatran and a general one for the factor Xa inhibitors. Those reversal agents are very expensive. They're not readily available at all hospitals, but they are in existence and available in the world for very severe cases. I think the availability or non-availability of a reversal agent for the DOACs is also kind of, you have to weigh that by the really quick off. They do wear off very quickly too, but they are available in the world. Go here.
Apixaban at a lower dose has been recommended, I think mostly based on age. What's the risk-benefit of that recommendation? Has that been looked at?
So the question was the lower dose of apixaban. Are you specifically about for AFib?
For AFib.
Yeah. So the question was about the lower dose of apixaban. There is a lower dose recommended. It's based on 3 criteria. It's based on weight, serum creatinine, and age. And if they have 2 or 3 of the criteria, then the recommendation is to reduce the dose. They haven't specifically looked at kind of patients who are on that dose versus the higher dose. So I'm not sure I can comment on that one specifically. In the middle? Yep. You.
I just have a question. I haven't seen any evidence in regards to aspirin and the colorectal cancer risk. And I was just wondering if you came across anything in those studies. And I haven't, but
There is some I didn't review it here today. There is some previous evidence regarding the benefit for colorectal cancer, and that's where the USPSTF recommendation comes from. It's only if you, that's where kind of also the 10-year use of it for 10 years comes from, because that evidence specifically required, they didn't see that benefit for colorectal cancer until it was used for 10 years. So there is some evidence providing the background for that USPSTF recommendation. I think in the one trial, the Spree trial, the increased risk of mortality in those elderly patients was actually kind of fueled by increased cancer risk, and it was specifically colorectal cancer. So that kind of now brings this question of, is it actually harmful in older patients but beneficial in younger patients? And that just, we don't have the evidence to comment on that. Behind, yep.
In your ACE and ARB versus lung cancer, did they compare those two versus just the incidence in the population?
So the question was about the ACEs and the ARBs with lung cancer, and did they compare that in the general population? I'm not sure just in the general population. They did do a secondary analysis compared to thiazides, kind of looking at something different, but still looking at this kind of a hypertension-treated patient. And they saw, again, an increased risk with the ACEs compared to the thiazides. But I'm not sure, I can't comment off the top of my head about the looking at that versus the incidence of just kind of the other patients from the UK. Here.
Actually, for the same study, I'm wondering how that, I don't know if I heard this. How did they handle smoking risk in that study? It was a huge study.
It was a huge study. They tried to adjust for that, I think, in their matching, or in their, yeah.
What was the question?
Oh, I'm sorry. My fault. The question was about in the ACE inhibitor cancer risk trial, how did they adjust for smoking? Did that capture it? Or how did they account for smoking? They did look at smokers versus non-smokers in a subgroup analysis. They saw certainly a lower risk overall in the non-smokers, but they still saw the increased risk with the ACE inhibitors in non-smokers and smokers. They did look at those in a subgroup. Yes, sir.
Again, the ACE inhibitor study, was it reported how similar or dissimilar were the pathologies of the lung cancer among those affected?
So the question was, again, in the ACE inhibitor and cancer study, if they looked at the pathologies, not that I'm aware of. I would have to look specifically, but I did not see that. Yes, ma'am?
They didn't bring this up, but long-term thiazide use is now, there's studies coming out showing increased risk of skin cancer and other cancers.
Mm-hmm.
Do you have any feeling, comment, blood pressure board?
Yeah, so the question was about some potential evidence for long-term use of thiazides and the association with skin cancer, and kind of my comment on antihypertensive use across the board. I'm not sure I can. I mean, unfortunately, I think there's always this risk of when we look at retrospective cohort studies, we always find an association with something that doesn't necessarily indicate causation. So I think, as with this study, probably premature to say that it causes it. Need more evidence to support that causation link. Sure. Yes.
Would you care to say anything about the cost of the advertising that goes along with
If I'd like to say anything about the cost of the advertising that goes along with the DOACs, not sure I'm probably the expert to comment on it, but certainly they are highly advertised, aren't they? And that's, I think, maybe part of my bias of saying there's lots of advantages to the DOACs, certainly, but I think that decision to say one is preferred generally over the other requires a lot more nuance and patient-specific thinking than is just preferred. So I know that didn't answer your question necessarily, but I will agree that they are highly advertised. Yes, sir.
Where's that trail?
Oh, yes. Thank you. I'd love to talk about that. It is the trail around Mont Blanc, so it goes right in the corner of France and Italy and Switzerland. If anybody can go or hasn't gone, you should go. It's really clearly marked, and there's little huts they call them huts, but they're much nicer than I think of a hut, along the way where you stop and you get dinner, maybe a beer, and breakfast and a lunch in the morning, and you go along your merry way. So it was amazing. But back to drugs, yes.
Speaking about pictures, you showed a picture in between the two sections with stone structure.
Yeah.
Was that in New Zealand?
No, that was I think it was right when we went over a crust and down into Italy. It was all on the TMB. So it was an old like little mountain hut that that one was really nice, and they'd redone it and had a little information booth inside. But
So it is a little disconcerting about this ACE inhibitor because we start people on them
Yeah.
every day,
Yeah.
and they're going to be on them for more than 10 years.
Yeah.
And I've been on one for more than 10 years, and if is the cost it used to be that we chose the ACE first because
for the cost. Yeah.
cost, and now that's less a consideration. So I must admit, it's why not go the ARB route and wait for more information?
Yeah.
Is what I'm thinking.
Yeah. So, for those of you who didn't hear that, the question was, like, what do we really make of this ACE inhibitors? We start them all the time. Usually, people are on them for more than 10 years. What do we make of this? I mean, I think I will share that. When I saw that headline, I kind of didn't want to believe it was true, and then you read the study, and you're like, oh, it's really. I mean, but again, should it make it so you never prescribe an ACE? I don't think so. There's lots and lots of benefits from randomized controlled trials of ACE inhibitors. This is, again, a retrospective study showing an association, but is it causation? I don't think we can say that. But if you're concerned about it, if the patient is concerned about it, I agree. I don't think, because we also have really good evidence for the ARBs, and I guess the absence of evidence doesn't mean it's not there, but we don't have the same evidence for ARBs yet. I don't think there's anything stopping you from using an ARB. And you're right, the cost difference is kind of negated now. If you had to pay cash for them, the ARBs are a little bit more expensive, but they're all readily covered.
I just saw the headline. I think the losartan relationship to cancer was specifically for the losartan hydrochlorothiazide, or there was a contamination. Or what was the
Yes. So the question is about the ARBs and what you might have been reading about cancer lately. So a lot of valsartan has been recalled. A much smaller amount of irbesartan and then one lot of losartan have been recalled, and it's all based on a contamination of the pharmaceutical product of the ARB from one particular kind of manufacturer. The contamination contains trace amounts of NDEA, and which is linked to cancer. There has not been any reported adverse effects, but it was recalled based on that contamination. So there is not a link between like the ARB itself and cancer. It's the contamination of the product on the market.
On that line, are pharmacies calling patients if they have that?
Great question. Yeah. So what's the process if a patient is on an ARB? So we get lots of questions about this. You or myself as a pharmacist on the Epic side, Providence side, cannot see what lot a patient got. And these are, a lot of times, like the losartan recall is one lot. So the only way to know is the prescribing, or the dispensing pharmacy. So both the manufacturers and the dispensing pharmacies have policies or workflows in place for contacting the patient if they received one of those lots. And if a patient is calling to ask, my consistent recommendation is that they call their pharmacy to confirm which lot they got and if they got an affected lot. For most of the recalls, the pharmacy can simply dispense a non-recalled lot. For some of the valsartan ones, because so many have been recalled, it requires a change to a kind of comparable ARB because valsartan is hard to get right now.
So how's the contamination discovered, and how did it get out into general public distribution?
So the question was, how was the contamination discovered and how did it get out to general public?
They have QA processes there.
Yeah, I guess I'm not sure who exactly discovered it. It seems to be kind of FDA based, but I'm not sure if it's kind of post-distribution QA. Yes, sir.
On television, they're now advertising for the Watchman procedure.
Oh, yeah.
Which hasn't not been covered by Medicare. Do you have any idea whether that is now
Yeah. Question was about the coverage of the Watchman procedure for Medicare. I cannot comment on that one. I do not know. Does anybody else know? Yeah, I don't know that yet. I will look into that.
Well, is the little appendage in the atrium where apparently all the thrombotic material comes from to cause the strokes. So now they're going and tying off that appendage, and therefore people after 6 months no longer have to take anticoagulants. But it's only been advertised, or only has been paid for by Medicare for specific situations. But I guess
Potentially, if they can't. Yeah.
I see the ads on
I haven't seen the ads yet, but good to know. Now they'll be coming asking for that. Great. Well, thank you all. Yeah.